how to communicate with a child with cystic fibrosis as well. So this is so important. If you have, like, say, two important star topics from respiratory system, it will be asthma and cystic fibrosis. Okay. So cystic fibrosis, how do they present? What are the common signs and symptoms? We all know, right? Usually they'll come with recurrent respiratory tract infection, then there will be failure to thrive, there may be loose stool or steatorrhea, etc., bulky stool, oily stool. These are the presentations. Okay, correct? But what happens in exam is that they can present with two things, because, right, they will not give you a child to take history in the clinical station. They'll give you a child and they will say, do the chest examination or examine the chest of the child. So cystic fibrosis commonly in clinical. After that, it can come in history, come in video station, less likely. Okay. Now say it came for you in clinical station. You have a child, you have an 8-year-old, or if you have, say, 5-year-old child comes to you, or 7-year-old. Okay, I'm taking a 7-year-old for some reason. 7-year-old comes to you and this is his first time, and they said examine the chest, and you saw that, you started examining and you are looking at signs. You see he has clubbed fingers. There is clubbing present. Okay. And you can see that he's having clubbing. All right, you're examining the child. You look at what are the features of cystic fibrosis. You look that he's not very well grown for his age. Okay. What else? You examine the chest and you see that there are some features of pneumonia. What are the features of pneumonia? There is bronchial breathing. There may be presence of crackles. That's all. Not very prominent features. And you also see, it's always advised. So when I teach the clinical station particularly, that time I will tell you what are the things you need to keep in mind. Okay. When you enter the clinical station, there are few things you'll have to keep in mind. One of the important thing is surrounding. In the surrounding, if you see an inhaler, keep asthma in your mind. In the surrounding, if you see any pancreatic supplement or any fat soluble vitamin like vitamin A, D, E, keep cystic fibrosis in mind. So if you see that, okay, there is a creon is pancreatic supplement, right? It's on his table. He looks small for his age. And then after that, what happened is that you find features of pneumonia. There is also clubbing. There is no scar mark, nothing. So it's not a cardio case. Then you will think this is a case of cystic fibrosis. Okay. Now, you want me to go through what will be the examination finding in cystic fibrosis? Will that be helpful for you guys?
Yes, ma'am.
All right. So what we are going to do is that first we enter the room, and after that we are going to examine the child. Commonly, cystic fibrosis can present with pneumonia. They can present with bronchiectasis. They can present with like anything, consolidation. So say this is the case of cystic fibrosis presenting with pneumonic consolidation. Okay. So what I'm going to do, my examiner is going to say, examine this boy who has shortness of breath, or examine his chest. Okay. So always I'm going to look for what are the things. I'm going to look for his height, weight. I'm going to look for if there is any cyanosis, if there is any respiratory distress, if there is any change in color. All this I'll tell you later. Okay, there's a formula for it. Okay, so I'll do my examination. What examination I'm going to do? Basically, I'll start and I'll see that the boy looks short for his age, or he looks thin for his age. He does not have any dysmorphic features. However, he seems to have a little bit of distress. Not distress, basically respiratory rate is slightly high. Okay. After that, I see there is some clubbing. Okay. Now I go for examining the chest. On inspection, usually what happens in long-standing case of cystic fibrosis, they may hyperinflated chest. Okay. And if it's a diagnosed case, you will have a portacath. If it's a new case, you'll not have portacath. Respiratory rate is slightly above normal. There may be intercostal, subcostal recession. There is usually reduced chest expansion, dull on percussion. Auscultation, you may find crackles and vocal resonance is increased. Okay, you found all that. All right. Now you will say, in order to complete my examination, I would like to palpate the liver. Because in cystic fibrosis, what happens? Hepatomegaly is one of the features. That's why you will say that. Okay, all right, done. You have examined the child. And you will say, your examiner will say done. You will say yes, done. You say thank you to the child, come to the examiner. Now your discussion part starts. Now they're going to ask you everything. So in the guidelines, I think cystic fibrosis guidelines is one of the most, I don't know, someone just called it poisonous guideline. Okay. It's a bit mixed guideline. What I meant by mixed guideline is that, can you see how many chapters are there for cystic fibrosis alone? 1, 2, 3, 4. There are like 4 chapters, and what they have done is that they have mixed it. They have not separated into new case, old case. Like, if it's a case, acute case of cystic fibrosis or newly diagnosed, how will you manage? If it's a chronic case, how will you manage? That's something they have not mentioned here. They have given mixed. Like in the treatment also, they said, oh, if it is long standing, do this. If it is short, if it is acute case, do that. They have not segregated the chapters completely. Okay, you can give this a read. I have made some notes. I'll give you the notes, but you can give this a read. There is no harm in giving read. But trust me, this many pages, like let me count how many pages is cystic fibrosis. 1, 2, 3, 4, 5. This 5 pages won't come in your exam. Sorry, 5, 6, 7. Yes, 7 pages. They won't ask you 7 pages long, and you won't have the time to explain all that to your examiner. Okay, so what we are going to study is that first we are going to study cystic fibrosis is a newly diagnosed case. What will you do? What investigation will you do? How will you manage the case? Okay, what are the antibiotics of choice you'll keep in mind? What is the prophylactic antibiotic? What are the complications? Okay, what are you going to do? What are the annual tests that you're going to repeat in cystic fibrosis? So once you have examined the patient, your examiner will tell you, all right, tell me, what do you think is the diagnosis? So considering the findings, I think this is a case of cystic fibrosis. This is my top differential. Okay, cystic fibrosis presenting with pneumonia. Okay, how will you investigate the child? So if it's a newly diagnosed case, I would like to always inform the cystic fibrosis team. Please listen. Cystic fibrosis, okay, diabetes team and cystic fibrosis team. Here in cystic fibrosis, this is the boss. Okay, they make the main decisions. Whether you're changing antibiotic, whether you're increasing the antibiotic, whether you're changing the route of the antibiotic, they make all the decisions. So you have to make sure you're always informing the cystic fibrosis team. Who are there in the team? You will have your consultant pediatrician. Sometimes you'll have a pediatrician who is specialized in cystic fibrosis. That's a super specialty level. Okay. Or you will have a respiratory therapist. You will have a specialized cystic fibrosis nurse. You will have a physiotherapist, a dietitian, respiratory therapist, social worker or psychologist, and pharmacist. Can you tell me why physiotherapist will be there? Okay. So consult. Yes, please.
For chest physiotherapy?
Yes.
Fix.
Usually they will have like the thickness of the secretions are usually very severe, like they're very thick secretions, okay, in case of cystic fibrosis. So they will not be able to expectorate the cuff. So in that case, basically we give chest therapy. It's something called half cuff technique. Okay, they teach you how to expectorate the cuff. That is the reason we need physiotherapy. Dietitian, why dietitian is important? Because this is cystic fibrosis lead to pancreatic insufficiency. So in case of cystic fibrosis, again, there is deficiency of vitamin A, D, E, K. So we need to make sure we giving them a good diet that is covering all this. Apart from the supplementation, will cover all the deficiencies. Okay. Respiratory therapist, again, if required. Okay. Usually the consultant pediatrician or pediatrician who has expertise in cystic fibrosis is enough. Social worker, because it's a long-standing condition, it's a chronic condition, the child may need some financial help. Okay, the child may also need psychotherapy. Because it's a long-standing condition, it does affect his emotional health, right? Also, we need pharmacist, specialist pharmacist. So they will be there in the cystic fibrosis team. The team consists of these many people. So whenever you say cystic fibrosis team, they'll just randomly ask you, okay, tell me who are there in the team. Okay. So say this 7-year-old child came to me. Usually cystic fibrosis in the UK, if we are considering, they do present very early because they're screened. But if we are considering a case, say, anywhere else, then we have to consider they can present at any age. Say a 7-year-old child has come to me and they are presenting with cystic fibrosis, and I have diagnosed them clinically after examination that this is a case of cystic fibrosis. Okay. Now, what will I do next? Always I will inform the cystic fibrosis team. Make sure to admit in cubicle. Can you tell me why cystic fibrosis is admitted in cubicle? Because commonly they come with atypical infections or infection with Pseudomonas, infection with Aspergillus, infection with Burkholderia capacica, all the atypical infections. So they're very highly contagious. You don't want that to be spreading. That's why we'll admit in the cubicle. Pertussis and cystic fibrosis, till now we have read who needs to be admitted in the cubicle. Okay. Now you're going to do some investigation. So I have divided the investigations. All these investigations are written in the guideline. Okay. I think more are written. First is you divide the investigations because it's very difficult for you to say all throughout. Like it doesn't look nice. You say, if it's a newly diagnosed case, I would like to confirm the diagnosis by doing a sweat chloride test and genetic test. To screen infection, I would like to do full blood count along with blood culture, urea electrolyte, CRP, LFT, and I would like to take the sputum for culture and microscopy. Since patients with cystic fibrosis are very prone to Aspergillus, right? Aspergillus infection, I would like to do specific IgE for Aspergillus. I would like to do a chest x-ray if indicated. But if the child has a chest x-ray, which has been taken recently, try to compare and try to not repeat it. Even in case of CT also, if it's not required, if it's not indicated, then don't go for it. If the symptoms are not severe, it's not indicated to do chest or CT. If you have an old one, try to compare and see. But if indicated, you're thinking this is the case of pneumonic consolidation, you're thinking this is the case of collapse, lobar collapse, then do a x-ray. So that's why they said if indicated and compare with the old one. Now, to check the lung function test, because cystic fibrosis is basically a problem in the lung. Then it comes to the GIT problem, then there is failure to thrive, then it goes to endocrine problem. So multiple problems. First, you're confirming the diagnosis. Second, you're doing a screening for infection because cystic fibrosis is very immunocompromised. Okay. Then you will do the lung function test because they come with the lung problem. What are you going to do? You'll do a spirometry if the age of the child is more than or equal to 6 years. We studied spirometry can be done above the age of 5 years. But what happens even after the age of 5 years? Most of the time they are not able to, they won't be able to follow the instructions during spirometry. Even for adults, it's sometimes difficult. Okay. So that's why if the age of the child is more than 6 years, you have to do a spirometry, and this is like top notch. At the same time, you check the oxygen saturation. Now, to screen for complication, check the glucose. Why is that? So what happens is that most of the children, at least 8% of children with cystic fibrosis, after the age of 10 years, they develop diabetes mellitus because exocrine pancreatic insufficiency will be there, and then later on it leads to endocrine pancreatic insufficiency. And unlike in pediatric population, what did we study? Normally, this diabetic ketoacidosis they present with, right? Type 1 diabetes present with diabetic ketoacidosis. But in cystic fibrosis, if a child is developing diabetes, they will usually present with weight loss. So if you see any child having weight loss, you think, okay, probably this child with cystic fibrosis is developing diabetes. Second thing, if the age of the child is more than 10 years, then you have to do OGTT, oral glucose tolerance test. But if less than 10 years, you don't do OGTT, just do glucose. So see, so if they ask you what investigation will you do to confirm the diagnosis, I will do a sweat chloride test. I would do genetic testing. To screen for any infection, I would do blood culture, full blood count, urine RME, urine culture. I would do sputum culture. I would do chest X-ray if indicated, LFT, CRP, etc. Okay. What else? To see the lung function test, I would do a spirometry at admission itself. Along with that, I'll check the oxygen saturation. To look into the complication, I would do glucose. I will check the glucose. Why you're going to check the glucose? Because a lot of children with cystic fibrosis, they develop diabetes mellitus. Is this clear about investigation? So to confirm, to screen for infection, lung function, and then for the complication. Okay. What are the other complications? Can you guys remember any complication in general for cystic fibrosis?
Bronchiectasis.
Yes, absolutely. That would be removed, like excluded with HSTX or CT, no? What else? GIT symptom, distal intestinal obstruction, right? So we have to look for that also. That is also one of the complications. So keep your eye open. That's not compulsory, okay? That's not compulsory to do abdominal X-ray or anything like that. But keep your option open. Like that can lead to distal intestinal obstruction syndrome. So look out for signs and symptoms. That's it. You don't have to go extremely into it. These are the basic ones. Okay. Now, how will you manage the case? This is the easiest management. I don't know how many pages the management is written, how it is written. I'm unable to follow that management. Okay. I'll just show you how the management is written later. So, simple case. Here you're going to go with a multidisciplinary approach and you will involve the cystic fibrosis team. As I said, this is the boss here. What are you going to do? Always you will admit the child. Okay, I forgot to write here, admit the child. So commonly in cystic fibrosis, we are considering this is the first case or for newly diagnosed case of cystic fibrosis. Immediately I will admit the child. I will, check his height and weight. I will do the spirometry. I will send all the investigations. Okay. After that, I'm going to inform the cystic fibrosis team. Since these children commonly have respiratory infection and I have diagnosed him to be a case of cystic fibrosis presenting with pneumonia or so and so, I will give antibiotic for the existing infection plus prophylactic antibiotic. So cystic fibrosis children, by the way, even if they are not presenting acutely, always you have to give prophylactic antibiotic to them. They're immunocompromised. Okay. Since this is a newly diagnosed case presenting to you with cystic fibrosis with pneumonia, you're going to give antibiotic for the existing infection plus prophylaxis. Okay. You're going to give some bronchodilator, salbutamol, meter dose inhaler. You're going to give nebulized Dornase alpha. Dornase alpha is basically, before they used to give hypertonic saline. Now they don't prefer it. They give Dornase alpha is basically a mucolytic, which breaks down the secretions or reduces the thickness of the secretions. Then you're going to go with physiotherapy and some advice from the dietitian. You're going to give him crayon or pancreatic supplementation. You're going to give him vitamin A, D, E supplementation and psychotherapy if required. This is just 6 points. You finish the management. Okay. So a patient has come to me. I have done the examination and my examiner is asking me, okay, tell me what is your differential diagnosis. So my first differential diagnosis, this is a case of cystic fibrosis. Okay, how will you manage? At first, I will inform the cystic fibrosis team and admit the child in the cubicle. I will send some investigation if it is a newly diagnosed case. To confirm, I will send for genetic testing, sweat chloride test. I will screen for the infection, CRP, blood culture, urine culture, sputum culture, all that. Okay, I would like to do spirometry and check the oxygen saturation. Since it's an acute infection, I would also like to go with the chest x-ray and then I would like to check the glucose. Okay, how will you treat the case? I would like to admit the case and then, as I have already informed the cystic fibrosis team, what I will do is that I will try to, after discussion with the team, I would like to give antibiotics to treat the existing infection plus prophylactic antibiotic, plus I'll give Dornase alpha, nebulized Dornase alpha, I'll give some bronchodilators, I'll involve the physiotherapist, I'll involve the dietitian, give pancreatic enzyme supplementation, I'll involve the psychotherapist as well. All right, okay. Now my examiner is asking me, what is your choice of antibiotic? Okay, so this antibiotics is a long portion because the choice of antibiotic in cystic fibrosis is very different. For acute infection, you're going to give different set of antibiotic. For prophylaxis, you're going to give different set of antibiotic. Okay, so since, as I said, we are treating this or we are taking a case of newly diagnosed cystic fibrosis, I'm going to teach from the beginning. If I say you a old case, if we consider an old case, then our plan of management will change. We are likely to skip a lot of points. Guys, are you following me? Do you guys need a break?
No, ma'am, it's fine.
No.
All right. Okay, try to engage and if you have doubt, if you want break, just stop me. Okay. I don't want you to waste your time outside class. Like, do class with me, study here. Okay. Now this child has come, okay, 7-year-old. Let us name him something, Leo. Okay. So 7-year-old has Leo, and I have admitted him, all right, and I'm thinking for his existing cystic fibrosis with pneumonia, I'll give him antibiotic. Now what happens is that I have to send for the sputum culture, but culture is going to take some time. So normally what happens is that these children with cystic fibrosis, commonly they're infected with Pseudomonas. So how am I going to clinically understand if it is Pseudomonas or not? It's not very reliable, but can I look into the sputum and understand?
Greenish
Rusty
color
sputum, I think.
Greenish color sputum.
Greenish color sputum. So I'll have some idea, okay, it is greenish color. It's not the normal pale yellow color or white color. Okay. So what happens is that if it is acute infection, always we have to give IV antibiotics. Now we are going to do sputum culture. In the sputum culture, by the way, so before the culture itself, we can start some medication and then alter, before that, like we can start with cefuroxime and alter, but again depends on the clinical condition, name of the color of the sputum, etc. So in acute infection, child just presented to me. Now I'll send for sputum culture. If it is no Pseudomonas or I'm not suspecting Pseudomonas, I'm going to give IV cefuroxime. Okay. But if I say in the culture it's Pseudomonas, or if I see the sputum shows like it's greenish in color, then I have to again understand if the child is symptomatic or asymptomatic. If the child has very severe symptoms, then I'll go with tobramycin and ceftazidime, these two medication. If child is asymptomatic, child is okay, not doing clinically, not doing very bad. Okay. But if it is green sputum, actually that will not be asymptomatic. So anyway, if it is asymptomatic, I'll give ciprofloxacin. Okay. Now these antibiotics can be given, it is primarily given IV. We can go with nebulized antibiotic as well, but after discussion with the cystic fibrosis team. So don't say nebulized, say IV antibiotics. I will start with the antibiotics, sir. In that case, if it is Pseudomonas, I'll send for the culture. If it is Pseudomonas infection, tobramycin, ceftazidime. In case of symptomatic, in case of asymptomatic patients, ciprofloxacin. In case if it is not Pseudomonas, I'll go for cefuroxime. Okay. After giving this medication for 7 days, if your patient is not improving, then you have to start with corticosteroid. Now, in so many questions or guidelines, you will see that they are receiving corticosteroid. You're thinking, why are they receiving corticosteroid, And moreover, administering corticosteroid actually has so much to do developing diabetes later on in life for them. So what's up? Why are we giving this? The reason is that only if the child does not respond after 7 days of starting the treatment, then you can give corticosteroid. Basically, you start with prednisolone. Okay, 1 milligram per kg per day for 7 days. This is your acute infection treatment. So acute infection, I'll give sputum culture, Pseudomonas. If they are asymptomatic, ciprofloxacin, simple one that we prescribe here and there. If it is symptomatic, tobramycin and ceftazidime. Okay. If it is not Pseudomonas, we are happy. We are just going to give cefuroxime. After that, also after 7 days, child is not improving, I'm going to give a steroid. Okay. And please remember, tobramycin is very important. Always to monitor tobramycin. It has a lot of side effects. So we have to monitor the levels of tobramycin. Okay. That's a separate thing. No need to remember. Just see, when you give tobramycin, you have to monitor. Okay. Now, prophylactically also you have to give, because I said that in case of cystic fibrosis, we have two treatments. First treatment is antibiotic for existing infection plus prophylaxis. For existing infection, you have selected tobramycin, ceftazidime according to your culture report. Prophylactically, what do we give? Prophylactically, we give oral flucloxacillin if the age of the child is less than 2 years. Okay? More than 2 years, they have not written anything, but you can give oral flucloxacillin or Cipro. Okay. But if the child is newly diagnosed and has never ever received any prophylactic medication, this is the first time he has been diagnosed with cystic fibrosis. Okay. And he has a Pseudomonas infection. So you start with tobramycin, ceftazidime, plus prophylactically, you will give cefuroxime for the first 2 weeks. Later on, you can convert to any other drug after speaking with the cystic fibrosis team. Okay. So I'll put up a case right now. Later on, we'll go forward with the complication. Okay. So say this 7-year-old boy, he's presenting to me with cystic fibrosis with bronchiectasis. Okay. Now, what I did is that I decided bronchiectasis. I decided to do a sputum culture, blood culture. I sent everything. And this came out to be a symptomatic case of Pseudomonas. Can you tell me what is your choice of medication?
Tobramycin and ceftazidime.
Cobra and ceftazidime. All right, you have given. And would you like to give anything prophylactically?
Yes, we have to give.
IV cefuroxime, since it's a newly diagnosed case. IV cefuroxime for 2 weeks. Okay. All right. Now say I have a patient and I did the sputum culture and it did not show any Pseudomonas. In that case, what would be my choice of drug? Cefuroxime. Okay. In that case, whether you should be giving cefuroxime for current infection and prophylaxis, that is something I'm a bit unsure about. Anytime you feel unsure about because you have to give double dose or not, you can consult with your consultant or cystic fibrosis team. Because this kind of level, this is not for a pediatric training. This is for someone who has specialized in cystic fibrosis. So it's absolutely fine if you don't know. You can say that, suppose your examiner is trying to twist. He's saying that, okay, this is not a case of Pseudomonas, so you're giving IV cefuroxime. Okay. What about this is a newly diagnosed case. So will you be giving IV cefuroxime for current infection, IV cefuroxime for prophylaxis as well? So you will say, sir, for the current infection, I will give IV cefuroxime. As for the prophylaxis, I would like to consult with my consultant or the cystic fibrosis team before making the decision. Dr. Ansa, I'm just muting. All right. So if he tries to twist it, they don't want you to give wrong answer, and they definitely don't want us to be a fake scenario or something. If they say you this thing, you can say that, okay sir, for the acute infection I would like to give cefuroxime IV, and for the prophylactic medication I would like to discuss with my consultant and then get back on this. That's all. Everybody is clear with cystic fibrosis treatment?
Yeah, clear.
Should we do a rapid fire before we move? Okay, let me complete this. Okay. Now, what are the complications or atypical infections? Okay, because the guidelines is given here and there. First, you study the basic treatment of cystic fibrosis. Okay, what is the basic treatment? These 6 points are the basic treatment. Then if he asks you, okay, tell me what is your antibiotic choice? Okay, you have asked. Pseudomonas, non-Pseudomonas. Suddenly he is telling you, no, the culture has showed another organism. It is Burkholderia capacica complex or BCC. What will you give? Immediately, if there is a very atypical organism, I would like to include my cystic fibrosis team, and the decision will be based on them. Okay, their decision. But mostly they give either meropenem or tobramycin. What if the culture showed methicillin-resistant Staphylococcus aureus? Again, I will inform the cystic fibrosis team, but usually they give vancomycin nebulized for 5 days followed by oral medications. Okay. What if the sputum showed aspergillus? That's a fungal infection. So in that case, I would like to give antifungal medications along with steroid. But again, I would like to consult with my cystic fibrosis team. Everything, put your cystic fibrosis team, okay? They can't blame you that why you asking. You know it, but you say that I would like to consult with them and give this. Okay, you're trying to say him that I'm very obedient. I will consult, but at the same time, I also have some idea. Okay. All right. Now say this child with cystic fibrosis developed chicken pox. What are you going to do? If he is taking oral steroid, that will definitely increase the risk. And in case the child has been exposed, the child has not developed chicken pox yet. He has just been exposed and he is non-immune. Non-immune means he has never received any vaccination, never has been exposed earlier, first exposure. And if he is taking prednisolone 1 milligram per kg per day for 1 month, or high dose, such as this is called high dose, okay, 2 milligram per kg, in that case, he'll give varicella zoster immunoglobulin. But if he has been receiving less than 1 milligram per kg per day, this is a moderate dose of steroid. In that case, you're going to give IV acyclovir for 7 to 21 days. So normally, we think that if they're receiving high dose of steroid, we have to give acyclovir. Okay, that's the conception we had previously. But guidelines says no. If they're receiving high dose of steroid, this is the high dose, we'll give varicella zoster immunoglobulin for exposure. But if they're receiving moderate dose, then we'll give IV acyclovir. For infection, if the child has developed chicken pox already, okay, if he's taking steroid, because we give steroid if he's not improving, right? Then always if he's taking steroid is in high dose, give varicella zoster immunoglobulin. If he's not taking steroid, you can give IV acyclovir. Along with that, you can give coamoxiclav as well. So remember, in cystic fibrosis child who develops chicken pox, if he's taking high dose steroid, along with high dose steroid, we avoid giving IV acyclovir. I'm not exactly sure about the cause, but if the child is taking high dose steroid, as mentioned here, you'll go with varicella zoster immunoglobulin. Similarly, if he's infected, if he's taking steroid, we avoid acyclovir. We'll give varicella zoster immunoglobulin. Okay. What about other infections? These children, they are immunocompromised. So with every season, influenza season is from October to Feb. So I'm going to give like influenza vaccine, pneumococcal vaccine, okay, as per the vaccination schedule. If he is having distal intestinal obstruction syndrome, any features of that, I will try to give first, Movicol. Then if child is not improving, I would go with stimulant laxative and then consult with the GIT specialist. Okay. If the child is developing diabetes mellitus, or say on glucose investigation, which you do initially as we studied earlier, if the glucose is high, in that case, you may need to consult with the endocrinologist as well. But normally, diabetes is another complication. If the age of the child is more than 10 years, directly you will do a OGTT. If the child is already on steroid, receiving steroid for a very long time, it's a chronic case of cystic fibrosis, you have to go forward and do OGTT. Okay. Since these children receive IV antibiotics very frequently, you will see a portacath. Okay. And it's very important that the portacath is cleaned. It has to be flushed every 4 weeks, not by you or me, by a specialist nurse, not by anyone at home, not simply washing with water. No. By a nurse who specializes in cystic fibrosis, we'll ask them to flush it every 4 weeks. Okay. So these are the complications that a child may face in case of cystic fibrosis. If it is atypical infection with Burkholderia, MRSA, Aspergillus, you will consult with cystic fibrosis team and then you will select the antibiotic. If you don't know the name of antibiotic, that's okay too, because here cystic fibrosis team take the upper hand. Chickenpox, we are saying that if they're receiving high dose of steroid, we'll go with varicella zoster immunoglobulin. If they're receiving low dose of or moderate dose of steroid, we'll go with acyclovir. Simple. Influenza vaccine, we'll make sure to give it. If they are developing distal or intestinal obstruction syndrome, we are going to give some, laxative, stimulant laxative, osmotic laxative. If not, features of, severe features of obstruction, refer to surgery, refer to gastroenterology. Developing diabetes mellitus, first I should know that this is a complication. So what I'm going to do is that if the age of the child is more than 10 years, I'm going to directly do OGTT. During the initial screening itself, I'll do OGTT. And if he is already in steroid, that also I'll do OGTT. Portacath, I'll have to flush every 4 weeks. Okay. This is the extra complications of cystic fibrosis. But up to here, this is the main investigations here. These are the investigations that you need to do. And this is the 6 parts, 6 points. This is the treatment. That's it. And then you go in depth in case your examiner simply wants to mess up with you. Okay. Annually, we have to do some screening. Okay. Ideally, we say it should be done during the birthdays. Okay. So this, because they should remember that. So what are the investigations that we do? We do a full blood count with a blood film. We do vitamin D, vitamin A, D, E. We do parathormone level. We do urea electrolyte, bone profile, CRP, glucose, very important, total IgE, specific IgE to aspergillus, etc. These are things that we do annually. This is all about cystic fibrosis from the beginning. Okay. Now I will make up a case, and will you guys practice?
Yes.
Okay. So I have this 7-year-old boy who's coming to me, and I'll tell you the findings. Okay. I have done examination. So you are my consultant. I have done this exam. Just a minute, guys. I have done this. I have this 7-year-old who's coming to me on examination. I found that he looks very small for his age, And I saw that on the side of the table, there was a pancreatic supplement. Okay, all right. And I saw there was some clubbing. On chest examination, I'm seeing that there is, features of bronchiectasis, say features of pneumonia, bronchial breath sound, there is crackles, vocal resonance is increased, etc., etc. Okay, so I'm thinking my differential diagnosis, this is the first. My DD is cystic fibrosis. All right. And this is the first time he has been identified or he has been diagnosed clinically as a case of cystic fibrosis. Now, what are we going to do? Tell me. Whom are we going to call first?
The cystic fibrosis.
Involve the cystic fibrosis team.
Hmm.
Admit in a cubicle.
Absolutely. Then?
And for a newly diagnosed case, we will do the diagnostic test, fat chloride test, and a genetic test.
Then?
And then for screening, we will do the full blood count, renal function test, liver function test, ESR, CRP, blood culture,
sputum culture,
urine culture, sputum culture, and if
blood
needed,
culture,
the chest X-ray.
Do the blood culture and sputum culture. Remember it in the first. Okay.
Okay.
Okay. Then.
And for the lung functions, we will do the spirometry, and along with this, we will do
oxygen saturation. I'll check the oxygen saturation. Correct.
Yes.
Okay. Then for the complication, there is a very important complication, diabetes. So what will I do?
Glucose.
Okay. In case the age of the child was more than 10 years, then what I would do instead of glucose?
OGTT.
OGTT. Okay. Now you have sent for investigation. Now what are you going to do? How are you going to do the treatment?
In the treatment, I will start to treat the acute infection along with the prophylaxis with the antibiotic. If it is a pseudomonas or not pseudomonas.
Don't say that. If I ask you, then say that. You say, I would like to give antibiotics according to the sputum culture for the existing infection plus prophylactic antibiotic. Then I would like to like that. Go on. If I stop you and ask, then you answer. Because if you cross that, right, your examiner won't know that what are the important things that has to be given. If he stops you, that's on him. Otherwise, you should not stop. You are going to complicate, because see, if you stop in the first line, antibiotic, you have to say this full entire page. So don't say that. Say directly 6 points. Then I'll ask you.
Okay. I will start the antibiotics for the acute infection and prophylaxis. And I will also add the bronchodilator along with the Dornase B alpha as a mucolytor. And I will also involve the physiotherapist and psychotherapist. And we'll give the pancreatic enzyme supplement in the form of the phenol along with the vitamins, fat soluble vitamins A, D, E, K.
Okay, so 6 points I'll give for the existing infection according to sputum culture prophylactic. Second, I'll involve the physiotherapist, dietitian. I'll give Dornase alpha. I'll give bronchodilator. I'll give vitamin E, A, D, E, Creon. Last one is physiotherapist, psychotherapist. Okay. Now I'm asking you. Okay, tell me what is your antibiotic of choice if it is a case of Pseudomonas?
Then in that case, I will give the IV ceftazidime and tobramycin along with the prophylactic antibiotic IV cefuroxime.
Cefuroxime. Okay. Is there anything that you would like to keep in mind when you give this ceftazidime and tobramycin? Yes, you would like to monitor the levels of tobramycin.
Okay.
Okay. So tell me, what is, what are the important infections that I need to keep in mind in case of a child with cystic fibrosis? What are the atypical infection apart from Pseudomonas?
These are the Burkholderia cepaci, and second one is the methicillin resistant Staphylococcus aureus. Then is the fungal, the Aspergillus.
Okay. Now, can you tell me, in case of a child presenting with cystic fibrosis and child is receiving corticosteroid for a very long time, okay, because his respiratory symptoms are not improving. So he has been receiving corticosteroid in very high dose and now he is exposed to chicken pox, but he does not have the symptoms yet. What will you do?
He is only exposed. Yes, in that case, I will give the immunoglobulin, VZIG.
Immunoglobulin. What if he is getting moderate dose?
In that case, we will give the IV acyclovir.
Okay. Now, annually, what would you like to look for?
Annually, I will do the investigations like full blood count, along with
Dr. Hajravi. Apart from investigation, annually check his height, weight. Okay,
yes,
because to come with failure to thrive, we need to check his height and weight and plot it in the growth chart. Include that. In fact, that has to be done immediately after the child.
Yes, you're right. And along with this, I will do the parathormone level, the glucose, and the renal function test, liver function test, and the IG level.
Okay. Okay. Everybody is clear. Dr. Hajra did an excellent job. You memorized everything. Okay. Anybody who wants to practice? Everybody is clear with cystic fibrosis? Okay. I missed out on one. Tell me who will be there in the cystic fibrosis team.
It is physiotherapist, respiratory therapist.
First, consultant pediatrician.
Okay, consultant pediatrician, the physiotherapist, the dietitian, and the psycho.